Hi, everyone. This is E. David Crawford. Joining me is my good friend, Daniel J. George. Dan is a professor of medicine and surgery, Division of Medical Oncology and Urology at Duke University School of Medicine.
Thanks, David. TheraP was a really important study, highly anticipated at this year's GU ASCO because of the excitement around PSMA, Lu-PSMA-617, and the VISION study, the phase 3 study, which just had a press release today demonstrating an overall survival and progression-free survival benefit over standard of care in chemorefractory setting. And that standard of care in the VISION study was with either abiraterone or enzalutamide in the sort of refractory setting to one of those drugs. What was missing from that study was the comparison to cabazitaxel, which has an FDA approval in the post-docetaxel setting, the same setting the VISION study was done in. So this TheraP study directly addressed that comparison. It was a large multi-center randomized phase 2 study presented by Michael Hoffman and from the Peter MacCallum Cancer Center in Australia, where they looked at patients who had PSMA-positive tumors. And interestingly, they did one extra step, which may not be standard of care. They took PSMA-positive tumors by PSMA PET, and they excluded tumors that were FDG-positive by FDG PET. So they really did 2 PET scans to identify the PSMA-dominant positive tumors. And then they were randomized 1-to-1 to either cabazitaxel therapy or to PSMA lutetium-617, and again in the post-docetaxel setting, and were able to demonstrate both a progression-free survival and at least a trend in overall survival benefit, as well as a statistically significant and robust difference in PSA response rate, greater than 50% decline in PSA. And so it really, I think, speaks to the efficacy of this strategy. They did compare toxicities, and they're different. We see maybe a little bit more of the xerostomia of the salivary glands with the lutetium agent, and we see more hair loss and cytopenias with the chemotherapy, more febrile neutropenia and things like that. We do see, some GI side effects, some nausea, some fatigue, et cetera, with both agents. But I think we don't see the neuropathy in this setting with these agents, and I think for a lot of the things that are limiting and confounding to our patients, both the bone marrow reserves, the prior chemotherapy and neuropathies and whatnot, I think this agent may offer both a safety tolerability as well as an efficacy difference than cabazitaxel. So both agents are active. We're excited to have more armamentarium, but it does suggest, at least in these selected patients that are FDG negative, that lutetium PSMA may be a really optimal choice in some of these docetaxel refractory patients.